Assalamu alaikum dear students, welcome to your channel The Anatomy Canvas. In today's class of Embryology Foundation module lecture 16, we are going to discuss with the placenta and the fetal membranes. So the learning outcome for today's class are to describe development of placenta and fetal membranes, to discuss the placental barrier and the placental functions, and to discuss RH incompatibility. So first have a look on development of the placenta. It is the major organ that facilitates the nutrient and the gas exchange between maternal and fetal compartments. By the beginning of the 9th week of the development, the demand for nutrition and other factors increases, causing major changes in the placenta. So in second month of development, initially you can see the primary villi are present, and these primary villi are formed by the core of the cytotrophoblast, which are covered by the syncytiotrophoblast. And this one is the section of the primary villus in which you can see the core of the cytotrophoblast is present, which is covered by the syncytiotrophoblast. With further development, the extra embryonic mesoderm forms the core of the primary villi, and then it becomes the secondary villi. So in secondary villus there is a core of the mesenchyme, which is derived from the extraembryonic mesoderm and covered by the cytotrophoblast and syncytiotrophoblast. And when this extraembryonic mesoderm differentiate into blood vessels, it forms the tertiary villus. So with the formation of the blood cells and the blood vessels in the tertiary villi, these vessels make a connection with the vessels which are developing in the chorionic plate, and these vessels then have a connection with the vessels in the yolk sac stalk. So in this way, initial feto-maternal circulation begins. In this diagram you can also see different villi, and these villas, they having this core of the extraembryonic mesoderm, which has now transformed into the blood vessels covered by the cytotrophoblast and then the syncytiotrophoblast. This one is the spiral artery, which is the blood vessel from the maternal endometrium, and this blood vessel giving the oxygenated blood to the developing placenta. The cytotrophoblast first invade these vessels and they erode this vessel, and as a result of erosion the blood enters into the intervillous space. And so the villi which are present from the chorionic plate till the cytotrophoblastic shell, they are called the anchoring villi, and these are anchoring villi are stem villi, and the free ends from which other villas originate, these are called the free villi. So in this slide you can see this one is the outer cytotrophoblast shell, and this is the intervillous space, and this intervillous space is bathed by the maternal blood. This is the spiral artery, and this is the vein which is taking blood away from the maternal circulation. Here you can see the developing embryo present in chorionic cavity. With further development, these cytotrophoblastic cells invade the maternal blood vessels and they replace the endothelial cells, and at this time the spiral artery become an hybrid vessels, and now it changes from a low diameter high resistant vessel to a low resistance vessel, as a result of which blood enters into the intervillous space and it bathes all of the villi present in this in the placenta. And when there is a pressure decreases over here, then this pressure, this blood goes back to the maternal vein into the maternal circulation. So this is the way in which the oxygenated blood is entering into the intervillous space and is going back through the maternal vein into the maternal circulation. This cytotrophoblastic invasion is very important because before the time of the invasion these vessels are high resistance and low decreased less diameter vessels, and if this invasion do not occur, which is a clinical condition called the pregnancy induced hypertension, so in such a condition this cytotrophoblastic invasion is either impaired or inappropriate, as a result of which there is a high resistance vessel which remains over here, and because of this maternal, there are the changes in the fetus which release certain cytokines which causes changes in maternal circulation, leads to pregnancy induced hypertension, and in severer form the preeclampsia and eclampsia, in which there is the excessive proteinuria and also the fits are present in the mother, and this condition is very dangerous. It's a leading cause of the fetal death as well as the maternal death. So this initial event, which occurs nearly 20th week of the gestation, is a very important, in which the cytotrophoblastic cells invade and they changes these vessels. Also in this diagram you can see this is the stem villi or anchoring villi, which is present in the center core of the mesenchymal core is present, in which the fetal blood vessels are present. It is covered by the cytotrophoblast and syncytiotrophoblast. This is the intervillous space, and in this space you can see the maternal blood is entering through the spiral arteries. So initially a barrier is present between the maternal circulation and the fetal circulation, and this barrier is formed by the four layers from outer to inner side. This is first layer is the syncytium or the syncytiotrophoblast, then is the cytotrophoblast, then is the connective tissue which is present, and then the endothelium of the fetal blood vessel. So this is the initial barrier through which gas exchange takes place from the maternal circulation to the fetal circulation. Also this is the barrier through which the exchange of different nutrients and product of excretion is also taking place. In fourth month, from fourth month onward, changes are taking place in the villi, and as a result of these changes the cytotrophoblastic cells become attenuated and later they disappear. Also the amount of the connective tissue is diminished, and then this placental barrier consists of only two layers. The outer is syncytiotrophoblast and inner is endothelium. So these are the changes which starts at fourth month and completes after the fifth month of the pregnancy, and this is very important because this barrier now allows many substances to pass from the maternal circulation into the fetal circulation easily. This is another very beautiful diagram in which you can see this is the maternal side and this one is the fetal side. Here you can see this is the maternal tissue and this is the cytotrophoblastic shell which is present, and which is this cytotrophoblastic shell covering the decidua, which is the maternal tissue. This decidua is called decidua basalis. These are the septas which divide the intervillous space incompletely, and these septas having core of the maternal tissue, and they are covered by the syncytiotrophoblast. And you can also see this is the intervillous space, and here you can see the anchoring villi and the free villi or the branch villi which are present, which are lined by the syncytiotrophoblast, and then the fetal endothelium, the endothelium of the fetal blood vessels. So this blood which is present in this space, which is coming through the spiral artery, this blood is bathing this primary villi and the branch villi and the stem villi, and the placental barrier is present over here. And these are the septa in which you can see the maternal tissue, that is the decidua, which is present, and this is covered by the cytotrophoblastic shell. This one is the chorionic plate, and in this chorionic plate you can see the umbilical arteries and the umbilical vein which are present. Two arteries and one vein is present, and these blood vessels present in chorionic plate giving branches to each of the villus, as a result of which this fetal blood is oxygenated from the maternal blood, and then it goes back through the fetal umbilical vein into the fetal circulation. So what is the placental membrane? This placental membrane separates the maternal blood from the fetal blood. It consists of extrafetal tissues. At 20th week of pregnancy, it consists of the four layers. As I have already told you that these four layers from outer to inner side are the syncytiotrophoblast, then the cytotrophoblast, then a small amount of the connective tissue and endothelium of the fetal blood vessels. After 20th week of pregnancy, the histological changes modified the structure of the placental membrane. So what are these histological changes are that because these cytotrophoblastic shell, trophoblastic cells become attenuated and finally they disappear from the placental membrane. At this stage, the placental barrier is formed by only the two layers, the endothelium of the fetal capillaries and the syncytial trophoblast. So placental membrane now consists of syncytial trophoblast coming in direct contact with the capillary endothelium. This placental membranes allows for the passage of the few endogenous or the exogenous substances across the membrane and restricting other substances, thus acting as a selective barrier. So this is the primary the stem villi, and these are the branch villi. This one is the chorionic plate, and these are the fetal umbilical vein and two umbilical arteries giving branches to the villi. So, what is the placenta actually, and what is the fetal? What are the fetal membranes? The placenta and the fetal membrane separates the fetus from the endometrium, the mucous membrane of the inner layer of the uterine wall. So, we all know that the uterine wall consists of the three layers. The innermost layer is endometrium, outer to this is myometrium, and then the perimetrium. So, the changes takes place in endometrium, and this endometrium is prepared for implantation, and after implantation this endometrium is helping to form the placenta. So placenta and the fetal membranes perform the following function and activity. The very important: the protection, the nutrition, the respiration, excretion and hormone production. Shortly after birth, the placenta and the fetal membranes are expelled from uterus as the afterbirth. The chorion, the amnion, the umbilical vesicles and allantois constitute the fetal membranes. So these are expelled after the delivery of the baby from the vagina. So what is chorion, frondosum and decidua basalis? In early weeks of the development, the villi cover the entire surface of the chorion. So in this diagram you can see these villi are developing and they are covering the entire surface of the chorion. Later at embryonic pole, the development continues, and these chorion will form the chorion frondosum, which is also called the bushy chorion. At the other side, which is the embryonic pole, there is the little development, and it is represented as the chorionic leaf, which become later on the smooth. So here you can see this is the chorion frondosum, and here you can see the chorionic leaf which is present. Also changes occur in decidua as well. So decidua refers to the gravid endometrium, the functional layer of the endometrium in a pregnant woman that separates from remainder of uterus after the childbirth. So three regions of the decidua are named according to their relation to the implantation site. So this is the chorion frondosum, and decidua in relation to chorion frondosum is called the decidua basalis. The chorion frondosum and decidua basalis, they collectively form the placenta. On the other aspect, on the embryonic pole, the decidua capsularis, which is present, so is the superficial part of the decidua which is covering the conceptus, and on outer aspect of the uterine cavity you can see the decidua parietalis. So as the embryo grows and the amniotic cavity expands, so these decidua capsularis and this decidua parietalis along with the chorionic cavity, they come into contact with each other and they fuses and they form the fetal membranes. And at this stage, whole of the uterine cavity is formed by the amniotic sac, which contains the amniotic fluid, and baby is floating in this. So at this stage, the decidua basalis and the chorion frondosum, they are basically forming the placenta. The decidua capsularis, decidua parietalis and the chorionic cavity are contributing to the fetal membranes. Here in this diagram you can also see this is the developing fetus, also the umbilical cord which is present. This is the yolk sac stalk. Here you can see the yolk sac present in the form of the cyst. This hole is the amniotic cavity in which the placenta is baby is present, and this is the chorion frondosum, also called the bushy chorion, and this is the smooth chorion which is the chorionic leaf. So in this slide you can also see this is the developing placenta which is formed by the chorion frondosum and the decidua basalis, and also this is the chorionic plate where you can see the fetal blood vessels are present which are connected to the vessels in the umbilical cord and giving the oxygenated blood to the fetus and carrying deoxygenated blood from the fetus to the placenta. This hole is the amniotic cavity, and these are the amniochorionic membrane which I have told you that formed by the decidua parietalis, the decidua capsularis, and the chorionic cavity, which all fuses with each other and they form the amniochorionic membranes over here. So structure of the placenta: by beginning of the 4th month, placenta has two components: the fetal component formed by the chorion frondosum and the maternal component formed by the decidua basalis. So on fetal side, placenta is bordered by the chorionic plate. On its maternal side, it is bordered by the decidua basalis, and decidual plate is most intimately incorporated into the placenta. So here also you can appreciate this is the decidua basalis. This one is the decidua capsularis. Here you can see chorionic frondosum and chorionic leaf. This area is the decidua parietalis. Here you can see the uterine cavity which is present, but in this, with the growth of the embryo and expansion of the amniotic cavity, the uterine cavity is obliterated, and the decidua leaf decidua parietalis, decidua capsularis, and chorionic leaf, they all come into contact with each other and they fuses and they form the fetal membranes. Placenta has two parts basically. So fetal part is formed by villus chorion, the chorionic villi that arises from it project into intervillous space containing maternal blood, and maternal part of the placenta is formed by the decidua basalis, the part of decidua that is related to the fetal component of placenta. So development of the placenta, as I have already told you, that in early placental development characterized by rapid proliferation of trophoblast and development of chorionic sac and chorionic villi. So by end of the 3rd week, the anatomic arrangement necessary for physiologic exchange between mother and embryo are established. A complex vascular network is established in placenta by end of 4th week, which facilitates the maternal embryonic exchange of gases, nutrients, and the metabolic waste products. So the uterus, the chorionic sac, and the placenta enlarges as embryo and later the fetus grows. So growth in size and thickness of placenta continues rapidly until fetus is approximately 18 week old, that is 20th week of the gestation. Fully developed placenta covers about 15 to 30% of decidua, and it weighs approximately 1/6 that of the fetus. In this slide you can see this is the fully developed placenta, and this one is the fetal side of the placenta, and this one is the maternal side of the placenta. On maternal side of the placenta, you can appreciate that large number of the cotyledons are present, and these cotyledons are formed because of the septum, which is formed from the decidua, and this septum divides the intervillous space incompletely and leads to formation of the cotyledons. On fetal side of the placenta, you can see the umbilical cord which is inserting into the chorionic plate, and also you can see the amnion. Here you can see the cut edge of the amnion. So there are the changes. Physiologically, this placenta is basically circular with the discoid margins, and usually has a central or sometimes eccentric position of the insertion of the umbilical cord. Umbilical cord normally contains 2 umbilical veins and 1 umbilical artery. Sometimes this umbilical cord inserts into the fetal membrane before entering into the chorionic plate, which is called the filamentous insertion of the umbilical cord. So these are the normal variants. Normally 15 to 20 cotyledons are present. Normal length is 15 centimeter. Diameter of the placenta is nearly this, and weight is nearly less than 500 grams, or sometimes called 1/6 that of the fetus. And it is a discoid shape and its insertion. So these are the different features of the placenta. Diameter 15 to 22 centimeter, thickness, mean thickness is 2.5 centimeter, and weight nearly 500 grams. This is fetal side and this one is the maternal side. So what are the functions of the placenta? Main function of the placenta is exchange of metabolic and gaseous product between maternal and fetal bloodstream, and also very important is production of the hormones as well. So exchange of gases such as oxygen, carbon dioxide and carbon monoxide is accomplished by the simple diffusion. At term, fetus extracts 20 to 30 ml of oxygen per minute. This is also your MCQ as well. So it extracts 20 to 30 ml of oxygen per minute from the maternal circulation, and even a short-term interruption of oxygen supply is fatal to the fetus. The placenta blood flow is critical to oxygen supply, since amount of oxygen reaching the fetus primarily depends upon the delivery and not the diffusion. Exchange of the nutrients and electrolytes also takes place, such as amino acids, free fatty acid, carbohydrates and vitamins, and it is rapid exchange, and it exchange increases as the pregnancy advances because the requirement is also increased. So transmission of the maternal antibodies is also very important. The immunological competency begins to develop late in the first trimester, by which time fetus makes all of the components of the complement system. So immunoglobulins consist almost entirely of immunoglobulin G type that begin to be transported from mother to fetus approximately 14 weeks. So you must remember this is the immunoglobulin G which can cross the placental barrier. This is again your MCQ as well. In this manner, the fetus gains passive immunity against various infectious diseases. The newborn begin to produce their own immunoglobulin G type, but adult levels are not attained until the age of the 3 years. Again, another MCQ as well. So different hormones which are produced by the placenta are by end of the 4th week. Placenta produces progesterone in sufficient amount to maintain the pregnancy. So if corpus luteum is removed from or fails to function properly, so before the 4th month of the pregnancy, usually near 12th to 14th week, the corpus luteum is producing the HCG and then the progesterone hormone, which is required to maintain the pregnancy. But by the start of the 4th month, the amount of the progesterone produced by the placenta is sufficient, and it can take over the functions. In addition to progesterone, placenta produces increasing amount of estrogenic hormone, predominantly estriol, until just before the end of the pregnancy, when a maximum level is reached, and it also releases the human chorionic gonadotrophin hormone and human placental lactogen hormone, which is also produced by the placenta. So during first 2 months of the pregnancy, the syncytial trophoblast produces human chorionic gonadotrophin, which maintains the corpus luteum. This hormone is excreted by mother in urine, and in early stages of gestation, its presence is used as indicator of the pregnancy. Another hormone which is produced by placenta is somatomamotrophin. Previously it was called the human placental lactogen hormone. So these are all the hormones which are produced by the placenta, and they are very important. Now the placental barrier, the maternal hormone do not cross the placenta. Hormone that do cross, such as thyroxine, do so only at a slow level. So some synthetic progestins rapidly cross the placenta and may masculinize the female fetus, such as synthetic estrogen, the diethyl stilbestrol. So this is very important because sometimes patient is taking the synthetic estrogen as oral contraceptive pill, and she even do not recognize that she is pregnant, and this estrogen, that is diethyl stilbestrol, has the property that it can easily cross the placental barrier, and it can cause the masculinization of the female fetus. So this compound produces carcinoma of the vagina, abnormalities of the testes in the individuals who are exposed to it during their intrauterine life. This is also very important. The oval line of the reflection between amnion and embryonic ectoderm, also called the amnio-ectodermal junction, is the primitive umbilical ring. So at fifth week of development, following structure pass through the ring. The connecting stalk containing allantois and umbilical vessels consisting of 2 arteries and 1 vein. The yolk sac, vitelline ducts accompanied by vitelline vessel, and the canal connecting intraembryonic and extraembryonic cavities. So this is the start of the fifth week of development. In this diagram you can see this is the fifth week of development, in which you can see the umbilical cord, which is containing the umbilical vessel and the allantois as well. This is the yolk sac with the vitelline vessels, and also in this cross section you can see the vitelline sac and the vitelline vessels, the 2 umbilical vein and artery, and the urachus are the allantois, which is also present. And this slide you can also see the intraembryonic and extraembryonic cavities are connected, and there is the physiological herniation which is present. These are the intestinal loop which are herniating through this umbilical cord. Also you can see the umbilical vessels which are present along with the allantois, and this one is the section of over here. And in this diagram you can see the intestinal loop, the extraembryonic cavity, the 2 umbilical veins and umbilical artery along with the allantois. So in this slide you can see the connecting stalk after the changes has taken place. So in this you see physiological herniation is also present. The umbilical, you can appreciate the umbilical vein which is present, the 2 umbilical arteries which are present. This one is a primitive umbilical ring. And in this slide you can see very important, this one is the median umbilical ligament. This is actually the allantois which is present. Later on which it will form the urachus. Here you can see this is the urachus which is attached to the apex of the urinary bladder and later on form the median umbilical ligament. So these all are also your MCQs as well. Another very important anomaly which is related with this development of the placenta is the erythroblastosis fetalis and fetal hydrops. So stimulation of the maternal antibody response against fetal blood cells. Some of the fetal blood cells, they can cross the placental barrier and enter into the maternal circulation, and they can cause isoimmunization over there. If maternal response is sufficient, the antibodies will attack and will hemolyze the fetal blood cells, causing the hemolytic disease of newborn. So more than 400 antibodies have been discovered, and these antibodies can cause isoimmunization, but the response is very little. Only severe response occurs in cases of CDE blood groups, antigens of the CDE system which are related to the blood group E. So if the mother is the Rh negative and the fetus is Rh positive, the antigens of the fetus enters into the maternal circulation where they elicit an antibody response, and this leads to isoimmunization. And when this antibody response is sufficient, these antibodies, which are usually of immunoglobulin G type, they crosses the placenta and they causes hemolysis of the RBCs of the placenta. So because of the severe hemolysis, there is there is stimulation of the erythrocytes, and the fetal blood cells are forming, leads to condition erythroblastosis fetalis. Now this condition is called fetal hydrops. In this condition there is edema and effusion into the body cavities, into the peritoneal cavities, into the pleural and pericardial cavities, and it can lead to the fetal death. So DRR and Rh antigen is most dangerous. The antibody response occurs in cases where fetus is Rh positive and mother is negative. The disease is prevented by identifying the woman at risk using an antibody screening and treating them with anti-D immunoglobulin. These anti-D immunoglobulins are very important. So if mother is Rh negative, we give injections of anti-D immunoglobulin, and if there is a chance of mixing of fetal maternal circulation, and if fetal RBC is entering into maternal circulation, they cannot elicit antigen response because of anti-D immunoglobulin, which will immediately destroy these antigens, and the baby will be prevented from the effects of the isoimmunization. So here I complete my today's class. This is a reference to Langman's Medical Embryology. Thank you very much for your attention for the today's class, and Allah Hafiz.